So how to treat this patient? Obviously, diet control, exercise, stop smoking. Weight is extremely important because if you see the pathogenesis of the diabetes, inflammation, diabetic kidney disease, all about weight and inflammation. Now, what are the particular medicines should be given? Is the first choice is metformin, SGLT2 inhibitor, RAS blockade, statin. Nowadays, we are using GLP-1 analog, receptor analog, but in 2017 it was not there. And antiplatelet and non-steroidal MRA, non-steroidal MRA was not there in 2017. And as I told you, glycemic control and blood pressure control and lipid management. So when we talk about the SGLT2 inhibitor, when to give this, it has become the first line of therapy. And when eGFR is more than 20, patient can be started on SGLT2 inhibitor and to be continued till transplant or dialysis is started. Metformin we can give when eGFR more than 30. How much to be given, whether dose to be reduction or not, it has to be individualized. But the stigmata of the metformin in chronic kidney disease has been removed. That FDA says that black box warning that creatinine, if it is more than 1.5, withdraw this metformin is now is not followed. All the recommendation says you continue, and then a high intensity statin, GLP analog is nowadays coming in a big way. If eGFR is more than 20, it can be given, but there are a lot of pros and cons about the cost and the tolerance. My experience is the tolerance is very poor because of the GI symptoms. Now, non-steroidal MRA we have to give if the patient is optimized with the ARB, SGLT2 inhibitor, and in spite of that proteinuria is significant, we must add the finerenone. Now, if the blood pressure is not well under control, we have to give CCB. Now, whether we have to give amlodipine or cilnidipine, there are controversies, but as far as the study is concerned, there is no head-on study between amlodipine and cilnidipine, but there are theoretical advantage of cilnidipine over the amlodipine or a dual blocker than the amlodipine alone. So blood pressure control, extremely important. We generally advise the blood pressure should be below 125. 120 to 125 is the target. So from 2017 to 2020, this patient's blood pressure was under control, 130 to 80. A little more we could have done, but this is the office blood pressure. This patient did not have edema. How did we treat? This patient received linagliptin with empagliflozin, so SGLT2 inhibitors, ARB. He was receiving 80 milligram of telmisartan. His HbA1c was under control. His creatinine in 3 years did not work, 1.9 to 1.6, then 1.8. Potassium was under control, and urinary ACR dropped to 1200, but later increased to 1800, and then COVID came. So when we start ARB, there are few problems generally we do see, and in practice, when physicians come across a lot of problem about. First thing is potassium. Now the potassium, we should not get worried so much of the potassium in CKD when patient is on ARB, and the tendency to withdraw the telmisartan, probably we'll see in this preceding next slides, that is detrimental rather. So potassium, we should be very careful, but when someone is on telmisartan, up to 5.5 potassium is acceptable. If goes beyond 5.5, you stop it. If between 5.2 to 5.5, and do not add or increase the dose, but continue the same. But if below 5.2, you can even increase the dose. And if it is below 4.8, you can restart again. Now, what about the eGFR? If you see the mechanisms of the ARB, it changes the hemodynamics inside the glomerulus. So obviously it is expected that the creatinine will go up. So the recent rise of creatinine after starting ARB or after increasing the dose of ARB is common and should be accepted. If increases more than 30%, then we should think about the reducing or stopping ARB, and simultaneously we should think about the other causes of the chronic kidney disease other than diabetic kidney disease. So rise in creatinine we have to take very seriously in favor of ARB, should not be stopped. So this patient from 2020 to 2022, limited access because of the COVID, his blood pressure was not under control, and at the end of 2022 when he came back his creatinine was 4.5, potassium was 6.2. Obviously I had to withdraw ARB, DAPA I had to withdraw, ACR was high, blood pressure was high, HbA1c was normal. So we switched over from amlodipine to amlodipine and later cilnidipine and then alpha blocker. And finerenone, that time we did not add because his potassium was high. And then 2022, if you see from 4.5 of creatinine, it did not improve even after withdrawing the ARB and rather progressed faster. So his blood pressure went up 160 to 170, creatinine went up, and then diuretics added, and all this a vicious cycle that to treat the patient's complications of the disease rather than treating the disease. So ultimately these patients went into a stage where patient required renal replacement therapy. Now whether we should dialysis or we should do peritoneal hemodialysis or peritoneal dialysis or transplant. Now in a given situation, in any patient, at any age, whether patient is having HIV or anything, except malignancy, the transplant always is better than dialysis in terms of mortality and morbidity and the lifestyle rather well-being. So he opted for the preemptive renal transplant. Donor was wife, and May 23 he underwent renal transplant. This is very important for the awareness in the society that the family members should come forward for the kidney donation. And I always propose about the related renal transplant. So the father-mother donating the kidney is becoming difficult nowadays because of the age problem, and many people are CKD, many people are diabetic. So most of my patients is that a wife or the husband is a good option. Here is the wife is a donor. Now when we talk about the wife is a donor, there is no HLA match, that means unmatched, unrelated. In spite of that, the kidney outcome or transplant outcome is excellent because of the advent of the very good induction regimes. We used ATG thymoglobulin from Sanofi. I used very low dose. Earlier, people in the Western country, they used to give 3 doses, three vials for 6 doses, and we reduced to so much so that we give only 50 milligram into 2. So with that induction regime, this patient did well, prednisolone, tacrolimus and MMF, and he is doing as far as the kidney transplant is concerned. At yesterday's his creatinine is 1.1. So this is the journey of the patient. That patient started with diabetic kidney disease, CKD, and doing good in renal transplant. So what about the CKD global burden? CKD is estimated to affect 50% of the patients in type 2 diabetes. In the United States, the 1 of 5 people with diabetes don't know they have diabetes. So the awareness of awareness among the patients and in society, and awareness among the physicians is important to pick up the diabetes at the earliest, is extremely important to prevent kidney disease. As many as 9 in 10 adults do not know they have chronic kidney disease. So I have seen many patients comes to us with long-standing diabetes and never urine ACR or creatinine was checked. So with you, I request everyone that if any patient has diabetes, do urine ACR and creatinine even at the onset of the diabetes or the first time you are doing, so that we can pick up the chronic kidney disease at the earliest. We know the importance of the control of the diabetes. More you control is the better in CKD prognosis. EMPA-REG outcome trial, you know that SGLT2 inhibitor is a wonder drug. It improves kidney survival, and GLP analog is another one, is extremely good for the kidney. And you know the non-steroidal mineralocorticoid receptor finerenone, this is also extremely good in the reduction of the composite CV outcome and composite kidney outcome. And last study has come about 7 days ago in NEJM. The combination of SGLT2 and the finerenone, they have additive function in the reduction of the albuminuria, reduction of the progression of the chronic kidney disease and kidney outcome. So probably these are the future of this treatment. Probably if I would have given these patients finerenone in 2019, probably the CKD end-stage renal disease could have been prevented for a year or so. So fourth pillar of the treatment of the chronic kidney disease in diabetes is the RAS inhibitor. Again, I am requesting to you that many prescriptions we get, the patient is on SGLT2 inhibitor and finerenone, but without ARB. No studies so far have been done without ARB. All the study of SGLT2 inhibitor and finerenone have been done where the patients receive maximum or highest dose of tolerable highest dose of ARB. So without ARB, nothing. So ARB should not be forgotten, and SGLT2 inhibitor is a really wonder drug. NSMRA is a very good drug, probably, except some problem with hyperkalemia we are coming across. It's a wonder to reduce proteinuria, and GLP-1 receptor analog. Probably because of the financial constraints, we are not able to use in a big way, but it's a very promising drug. So my take-home message is early diagnosis and management of the CKD in diabetes is critical to prevent the long-term morbidity and mortality in this population, like this patient is landing up in transplant. It is especially important that the tool for diagnosis such as eGFR and urine ACR are readily available. Today's medications, especially RAS inhibitor, SGLT2 inhibitors, non-steroidal MRA, GLP-1 receptor analog are highly effective both as monotherapy and in combination. Thank you. Thank you very much. I had to run because of this constraint of time. Any questions, I'll be glad to answer.
Thank you, Dr. Partho Kormakar, for your excellent